All right. Good afternoon, everyone. Thank you all for being here. Welcome to the second panel in the Lucy Family's three-part series on AI for society. So I recognize a lot of faces. For those of you that are here for the first panel, as we know, we explored how AI might be designed, right, to cultivate human capacity, like learning, empathy, creativity, rather than replacing it. That kind of laid our foundation for the series, the idea that the promise of AI lies not necessarily just in optimizing individual performance, but in strengthening the conditions that allow people to grow. So today we're going to continue that conversation in one of the most consequential domains for AI, health. In the past decade plus, kind of the prevailing narrative around AI in healthcare has kind of focused on personalization, right? Smarter diagnostics, tailored treatments, individual wellness tracking, things like that. So the harder question that has been left mostly unasked is, what would it look like to design and govern AI systems that strengthen community, expand access to care, address structural disparities, right, and who gets well and who doesn't. So this panel, right, AI, health, and the common good, is going to explore that. So our panelists, right, we have expertise spanning data privacy, global health equity, trustworthy machine learning, and health information systems. So the goal of today's panel, right, is not to just be a conversation about better health technology, but a conversation about better health systems and about the responsibility we carry as researchers, designers, and so on to ensure that AI serves not just the patient in front of us, but the communities around them as well. So I will go ahead and introduce our panelists today. We have Corey Engst as the Jack and Joan McGraw Family Professor and Chair of the IT Analytics and Operations Department. Corey is a leading scholar whose work has defined the modern understanding of digital transformation in healthcare. His doctoral dissertation remains the most downloaded in the history of the University of Maryland, reflecting the profound influence of his work on nearly 50,000 practitioners and scholars seeking to better understand the role that health IT plays in transforming the healthcare system. Since then, his research has shaped our understanding of how health IT diffuses through hospital systems, how data breaches expose hidden organizational vulnerabilities, and how digital platforms can replicate or challenge societal biases. Thank you, Corey, for being here. Our next panelist is Angelica Garcia-Martinez, and assistant research professor at the Lucy Family Institute, whose work sits at the intersection of artificial intelligence, health equity, and community-engaged digital innovation. She studies how AI can move beyond individual care to address the structural drivers of health disparities, particularly among underserved communities in the United States and Latin America. She leads the design of community-informed digital health systems, including, and I meant to ask you how to pronounce this beforehand, but Salud Conecta, all right, Salud Conecta, a platform supporting caregivers of children with cancer through accessible information and care navigation. Built for families often navigating treatment without insurance or reliable access to care, her work reflects the central theme of this panel: designing AI not for individual optimization, but for the communities most often left behind. Our third panelist is Feng Liu, a Notre Dame collegiate professor in the Department of Applied and Computational Mathematics and Statistics and director of the Health Data Exploration and Analytics Lab. Her work in differential privacy helps us address a central tension in health AI. The data needed to track disease, allocate resources, and understand disparities is also the data that most demands protection. Her career spans pharmaceutical research, where she contributed to treatments for type 2 diabetes, to large-scale clinical trials for malaria prevention, to her foundational work in privacy and trustworthy statistical learning. Her research focuses on ensuring that efforts to generate community-level health insights do not come at the expense of individual privacy. And finally, we have Fanny Ye as the Galassi Family Collegiate Professor in Computer Science and Engineering and Associate Director of Applied Analytics at the Lucy Family Institute. Fanny is a world-renowned leader in using integrated AI to solve life-threatening health crises. Her research spans AI systems for real-time COVID-19 risk mapping to large-scale AI frameworks, leveraging social media to shield vulnerable youth from the opioid epidemic. Through her focus on scalable and robust AI systems, Fanny brings a critical infrastructure perspective to our conversation, reminding us that community health AI is only as trustworthy as the models it is built on. So thank you to all of our panelists for being here and give them a round of applause. So I'm going to open up the panel today with a question for anyone who wants to jump in. As we kind of heard in the opening for the panel today, a lot of the conversation has been around this personalized health tracking, right? So in your opinion, is there a tension between personalized medicine and public health AI, or can the same systems genuinely serve both goals? Anyone want to start us off?
Happy to jump in.
Yeah.
So their tension, I would say there absolutely could be. There doesn't have to be. Maybe I should start with at least my definition of personalized medicine and population health. But I view personalized medicine as medicine that's specifically tailored towards you as an individual, not you as a demographic or a race or an ethnicity. I was recently surprised to learn that you can do a blood test and find out exactly which antidepressant medicine you should be taking of the, I don't know what, 30 or 40 different medicines. So that's personalized medicine. Population health, and Angelica could definitely define this better than I could, but I view that as like, how do we treat communities? How do we treat people in groups or people that are in specific zip codes? I think the easiest way to talk about this tension is to give a brief example. I don't know, have you all heard of ambient listening that's being used in healthcare? So some of you, in this community alone, we're well over 500 doctors who are using it. But the basic idea, if you haven't, is that, you walk into an exam room and doctor walks in, says, I have a AI that can listen to this conversation and codify it, transcribe it. And most of them say, and it would allow me to treat you better. Are you willing to let me record this? And according to the people I'm talking to, 95, 97% of the patients let them do that. But this is designed for the individual. It's designed for that particular episode of care. But what it does is it speeds up the process. So it records everything. The doctor walks out of the exam room and he or she has a doctor note that's ready for them. Takes away the burden of them having to document themselves. One of the things that doctors hate to do, if you happen to know any of them. But the most important thing, this gets to the population health level, we are getting narratives now of the conversations, detailed dialogue, things like talking about personal relationships, talking about the fact that I can't get my mother to care, all these really rich conversations. When we start taking that information and aggregating it with all of the other ambient listening technologies that are capturing this, we can start to get a pretty good idea of what's going on at the population level. So if we use these things correctly and think of them not just as technologies that are designed to give me better treatment from my doctor, but also thinking of it in a more global sense, there's no question it can help us with population health. I'll stop there just in case others want to chime in on this.
I can. Yeah, go ahead. Yeah, I can add some more. I actually very much agree with what's being said by Corey, and I also agree with Corey. I don't see this is a straight trade-off, but instead I would consider this as a design challenge. So personalized medicine focuses on individuals, but public health may focus more on the population, especially those kind of marginal community or vulnerable. And where is the tension arise? Actually, it arises when a highly precise system benefit only a few, but don't scale accurately. So this is the part I think where the tension can arise. But I would use the opioid crisis I've been working on for a decade to illustrates my points. I think the opportunity is like AI system can do both. How can we enable AI system to do both? Using the opioid as an example, it can predict individual overdose risk and also trigger intervention. And leveraging those kind of precise data generated from individual, we can also identify hotspots and guiding that kind of resource allocation, etc. That is one of the example. So the goal for the design of AI system is not only precise, but also actionable, connecting those prediction in to intervention and also policy, and make sure that it's going to benefit broadly share. So in one word, I would think AI for health must be both individually intelligent while collectively responsible. So the goal is not to choose between personalized medicine and public health. That is to design AI system where improving one enforce the other. That's my point.
Maybe just first I want to say I'm probably the most underprepared panelist. I don't have any notes, right? So the panelists.
You're the smartest.
Also, I just came back from back-to-back teaching, so my blood sugar level is really low. If we hear me saying something crazy, don't just yeah. Anyway, I think it's actually they're not attention. They actually benefit each other. So let's say if everybody have their own best treatment, will the population level health be at the best as well? I think the attention probably only lies when how to allocate resource. If the personalized medicine really closely, you have limited resource, you probably can only focus on part of the individuals rather than whole. But as long as there's no tension in resource, it shouldn't be a problem.
Yes, probably I would like to, I'm totally agree with your comments. Okay. However, I think if we consider that it's practically impossible to go through a personalized medicine for many reasons, okay, probably it's only applicable for specific areas. At the end, we need to figure out how to resolve the big issue that we have fragmented systems that at the end probably are not connecting between them, and there are no resolving the specific issues that we are looking on the side of the health systems. Let me explain why. If we look how the evidence are growing in the side of medicine, as also in the side of the technology. Okay, the health system are totally disconnected, and it's impossible, at least if you have money and the infrastructure to invest and do something. Okay, at the same velocity that we are generating this evidence, it's impossible to get it as a reality. So I think that the solution is definitely to think in technological innovation, trying to understand exactly what's the meaning of the things or the values that we are thinking when we say common well, for example, and yes, I think that is the crucial points that probably I would like to put on the table, for this question.
Yeah, absolutely. Thank you, all of you. Maybe we'll come back to Corey now. So, talking about the push for all these doctors in town to adopt ambient listening and what their motivations may be. It seems that at a broader level, right, most health investment flows towards profitable clinical tools. What sort of institutional incentives would shift innovation maybe more towards this lens of public health?
I don't have any providers in the audience here, do we? So I'm going to say something that's provocative, but not necessarily my opinion on this. The short version of this is that innovation follows incentives. If there's incentives there, people are going to innovate. Those incentives right now are not necessarily aligned in the way that we deliver what you're talking about. Most technologies are designed to either increase revenue or reduce costs. They're less so designed to improve population health, for example. So how do you do that? I gave one example already of, well, you take the technologies that were designed for improving revenue, reducing costs, and you reconceptualize them in ways that how do we capture the data that's coming out of that so that we can offer care at a population level that doesn't cost us a fortune to deliver. Some ideas that people have talked about, using AI for disease detection, but the more controversial stuff is like, how do we shift the responsibility back to the provider? Things like capitated care or ACOs, accountable care organizations, where doctors are incentivized to make sure that their patients are healthy. So, we actually have some of these here in town as well, like concierge care, some folks call it that. The doctors that you pay a flat fee to, and then you can see them as many times as you want in a given year. The only thing that you pay for is like extraordinary care, if you had to have surgery or things like that. So it's in their best interest to keep you healthy. Now, if you were able to incentivize a system like that, then things seem more aligned, and potentially it could, deliver the types of things you're asking for. How do you do that? You do have to give them the tools, particularly if we're talking about artificial intelligence here, to be able to, access those tools in an inexpensive way that allows them to reap the benefits. So, evidence-based care delivered at the point of care, artificial intelligence that's listening, analyzing everything that's being said, and not just transcribing a note that's prepared after the visit, but actually providing information to the clinician at the point of care. These are the things that, ultimately will help with the patient in front of you. But if we do it in the right way, we can actually bring that up to the population level as well.
No, it's very insightful. I think definitely the idea of concierge care for public health in some ways is an interesting thing to ponder for sure.
Well, yeah, and I would say this: it's mostly limited to people that are at the upper end of the income scale, and we have to figure out a way to bring that down to the general population as well. And maybe that's through, value-based care and accountable care organizations, but nobody's figured out that model perfectly yet.
Fanny, you've had considerable success in actually addressing some of these problems with some of the technology that you have worked on for your career. We know that public health crises, right, are fundamentally networked problems. So how does modeling health systems as networks change the kind of interventions we can design?
Thank you for asking it. Yes, indeed, many of public health crisis can be considered as a network problem instead of just considering them as a silo. So we can just abstract that kind of public health crisis as a graph or network, because risk spreads through relationships, environments, and also institutions, not just through individuals. And a graph-based learning models can help modeling this connection directly. Still, I use the opioid epidemic as an example. A graph-based model is particularly valuable because we can model this as multi-relation systems, and individuals are linked not only because of the disease itself, but also to other individuals. And as Corey mentioned, it can also link to different providers, community service, like providers, healthcare providers, neighborhood substance, and also social determinant, as well as like policy environments. And naturally, like a graph or network is a great model to actually abstract all these complex relations together. And it also allows us to represent that kind of heterogeneous relationships clearly, explicitly, which make it possible to detect, for example, hidden dependency, identify intervention reach point, and stimulate how local change may affect the broader systems. So, the real value of like a graph-based AI models or like learning system is that it helps us move from isolated prediction to system-aware intervention.
You think you can maybe walk us through just like a brief example of like your some of the work that you've done around the opioid epidemic? Like how has that kind of come to fruition and been as successful as it has been?
Sure. Actually, we tackle like the opioid crisis from two perspectives. One is from like a supply perspective, like we actually devise like AI-driven models to detect and also dismantle that kind of online opioid trafficking network. And then you actually use like that kind of graph-based model for the detection of opioid trafficking communities online. It's actually like nowadays, like those kind of trafficking co-evolve with modern technology, such as like a crypto market hosted in darknet, has been used like widely for the trading of illicit drugs, not only drugs, but many other kind of products. And even like a popular social media platform such as X, Instagram, has become like a direct to market medium to like trade this kind of illicit drugs, advertise this kind of new synthetic opioids. And then with like that kind of graph structured data, we build a model to detect the trafficking communities. And interestingly, there are some kind of insight learned from these detected communities. For example, it's interesting, like if I ask, for this kind of different social media platform, which platform would be like more active for opioid traffickers versus opioid users? Do you guys have any idea?
Traffickers versus users?
Yeah, just ordinary users, like which platform would be more prevalent for opioid traffickers?
Craigslist or
Like
that used to be the big one.
our like insight joined from our developed like graph models. Interestingly, like compared to X, like drug traders, drug traffickers would be more active in Instagram, and ordinary users may be more active in the discussion in a platform such as X. That is like a kind of novel insight joined from this kind of graph-based model. You asked me to give some example, and also another interesting insight is like do you think like a drug trafficking they focus on selling or advertising single type of drugs, or is there any kind of mechanism behind what, like if someone just like advertise sell illicit drugs online on social media, they prefer to sell multiple type of drugs, or they just like focus on one type of drugs? That we also have some kind of interesting findings, and how they interact with each other, like online. So like a different role, like how they interplay with each other. That are all those insights conjoined from like the graph-based model. That is from the perspective of like trafficking, and we also did a lot of work from like users' perspective. Aiming to save people's life. For example, supported by like the poverty initiative. And it's always like a great pleasure to work with like Fred and Ali from Poverty Initiative. Like beginning from last fall, like initiated by Provost Office. I'm leading like the opioid like working group together with like a Poverty Initiative, consisting of 19 researchers from 12 units across campus, and from like a user perspective, like actually many type of crises just like intertwined together. For example, poverty-driven food insecurity has strong connection with the opioid crisis, but how they just like reinforce each other, and what kind of data we can harness. And based on that, like we also have some kind of interesting findings built upon like the graph learning models. For example, like how can we identify intervention leverage points and what will be the hotspot and how naloxone could be best distributed to prevent opioid overdose risk or overdose deaths. That would be another example.
Yeah.
Thank you.
That's incredible. Thank you. Yeah. I think one question that might come to people's minds when they think about these technologies that are incredibly impactful, right? But looking at such vast and often sensitive data, right, is the question of privacy. So, can you maybe talk a bit about how work like differential privacy or other developments in this field might address some of the larger privacy concerns that come from this drive to help public health?
Gosh, that question sounds different from the note you give us. I'm just
Okay, I'm off the top. I can read it, but
so it's like how do you use differential privacy to help us to?
Yeah, what role does differential privacy have to play here when we're talking about public health AI and the sensitivity of these large scale data sets?
Anybody aware of the concept of differential privacy, or do you want to give the lecture here?
Oh, you're the expert here.
Well, differential privacy is we just call that DP. It's a very mathematical abstract concept for a privacy guarantee when you release information to the public. Just give you a concrete example. Let's say Corey makes a lot of money.
It is true.
Yeah,
Yes.
say that.
And I want to estimate the average salary of the whole room, right? So without Corey's data point, there's gonna be a big difference.
Mhm.
And so you can sort of figure out from the two averages and calculate Corey's salary. So how can I protect Corey's salary? So before I release the average salary, I'm gonna perturb the average salary with some noise term. And then the noise term is for example, could be coming from a Gaussian distribution. And the scale of the Gaussian distribution of the appearance term of the Gaussian distribution is calibrated to a pre-specified privacy level guarantee. So if I want more privacy guarantee for Corey, I'm gonna add a bigger noise. If I want less privacy guarantee for Corey, I'm gonna add a small noise. So that's how you kind of protect people's individual level data using differential privacy. We call that randomized mechanism. So I think from that concept, we start to know how we can sort of deploy the DP or differential privacy mechanism in gathering data, right? So every time I release data, I don't just release the data as is. I'll always kind of feed the data to a DP mechanism and I'm going to release the perturbed results. You can do everywhere. You can do with AI, without AI. You can do during the data collection stage. You can incorporate DP when you analyze data, formulate an AI model, or you can sort of feed the output from an AI model to a DP mechanism and release the output. So there's like the various stages of the data, whole data life cycle. You can incorporate DP. The thing is more about there's always a privacy and data utility trade-off. You add noise to the data. The data will be perturbed. It does not carry as much information as should carry from the beginning. I think that this is an ongoing research topic. It's the most fascinating topic in privacy research. You want to always come up with the sort of mechanism that I can guarantee people's privacy, but without sacrifice a lot of data utility. I would say it's not a problem incorporating into AI-driven health system. It's more about how to design the system to make sure data is still useful without compromising people's privacy. Stop there.
Yeah. Is there anything different about public health data when it comes to protecting privacy?
I think actually it's better because public health data, I would say the data volume is large. There's a large pool of data. If the pool is large, nobody cares who you are. So individual privacy actually in some sense is automatic guarantee. Or in other sense, you don't need as much noise to guarantee people's privacy if the pool is large. I think it's more about how to sharing data. Of course, different organizations, right? In public health, you could have data collected from St. Joseph County. You could have data collected from Goshen County. Maybe they don't like to share with each other the data. Maybe you can build the so-called federated learning. You don't have to share individual level data. You just share aggregate sort of information. Yeah, there are ways of like people working on this. It's not something new, but I think it's a problem can be conquered.
So bringing it back to the example of Corey's salary, if we went to the broader university,
Yeah.
I know Nitesh isn't here today, but maybe having Nitesh's salary and the data would maybe protect Corey's privacy a little more. Yeah,
For sure.
perfect. So move on to Angelica. From your perspective, right? So, when we talk about privacy, that causes a lot of trust issues when people are, maybe being subject to ambient listening and they don't want their conversations recorded, whatever the case may be. I think there's a lot of concern around how people actually will have a say in the public health systems and their own medical decisions and where their data goes and anything that comes with that. So in your opinion, and the expertise that you have, how can communities meaningfully participate in designing these AI systems that subsequently affect their health?
Yes. Okay. Okay, I'm going to back again to on behalf of public health and epidemiology. I need to express something. Okay. Imagine that we have multi-systems, okay? All of them working or creating loops of information responding to specific needs that they have, okay? Then try to connect all of these systems between them, okay? Probably we have some tiny connections between them. At the end, it's impossible to, the final conclusion here is why we are still fighting for the same diseases, okay, that are prevalent, okay, for the last 50 years, okay? So that is one point that I would like to put here, okay? The other one is when we're talking about, for example, okay, how can we are going to protect your data and your information, and sign here? This is the consent letter. At the end, working with people with low education level. Okay, they don't have any idea about what you are speaking of. Okay. When you said, okay, the privacy about what? No, they don't have any idea. So that is something important that we have to look at the end, and how we are going to make sure that they are understanding exactly how we are going to do this protection. And I would like to close, responding to your question, saying, okay, connecting these two ideas is, at the end, we need to work in participatory governance. Okay, that means that all the voices are important. All the voices have been involved end to end in order to make sure that all of us are understanding exactly what is the common good and how we are going to reduce significantly the main problems that we are facing in public health.
Yeah, thank you. And, I think one specific area too that has had a good amount of conversation around it is maternal health. Do you have any particular insights in what AI systems might look like when we talk about maternal health, or how that might, assist doulas, midwives, OB/GYNs to care better for
Yeah, it's a very sensitive topic. Okay. I worked for 15 years at the National Institute of Public Health in Mexico, working with midwives and doulas and trying to test different models to reduce maternal mortality. At the end, we designed a beautiful intervention named Pronto. Is live, is ongoing in Africa, Latin America, India. The target is to reduce maternal mortality, something that it's, again, one of the biggest problems. It's not only for the loss of these women, is how impacting in our societies in terms of once a maternal mortality happened, okay, what happened with the rest of the family? And I think here AI tools are super relevant. Why? Because these providers are working on field. They know exactly what the community needs and how to resolve their problems. So probably we create, for example, and I'm assuming there are tons of them running right now on field. But yeah, the thing is that if we, for example, create these tools tracking signs and symptoms, that probably alert us about an imminent complication, okay, that will be fantastic. But I think the most important thing here is that any intervention should be accomplished with an educational intervention too. So we need to figure out how to run simultaneously these two aspects, because if we don't improve the knowledge of the population, in particular unserved population, it's going to be very difficult to move forward and get exactly the results that we are expecting in health.
I want to leave a little bit of time at the end for questions from the audience. So start thinking about those if you haven't. But I'll ask one final question to the entire panel, anyone who wants to answer. If, as we suspect, AI does become deeply embedded in public health systems, over the next decade or two, what metrics do you think we should use to evaluate whether it's actually serving the common good or not? Mm-hmm. What should we be measuring? Ben?
Yeah, I think I can start with this. I think if AI is deeply embedded in public health, definitely not only accuracy, efficiency should be the metrics to be considered, but instead we should ask if it really improves health outcomes, reduce disparities, leads to real-world interventions, and public trust, and also strengthen the system as a whole. So in other words, the real metric is not just whether the model performs well enough, but whether it produces equitable public value.
So we should collect data now. That's the baseline. Yeah. So, and we can use the method that Fanny mentioned and to do the pre and post comparison. But the data is very important. We should start now.
Yeah.
I mean, the biggest thing for me is bias. We've learned lessons on this already with AI. If we learn, that's a really hard lesson to learn when we're talking about people's lives. We've got to figure out what the biases are, where they exist, how we get rid of the biases that are there. Detecting that this is a real challenge.
Yeah. Yeah, probably I would like to back to this idea of different multi-systems, and how they are collecting information right now. I think that the challenge is how to create permanent loops of information that could be tracking, in a sustainable manner across the time. If we look different spheres of information that we are aggregating, probably if we go to the individual level, okay, we need to understand how to get the best approach about what's the meaning of this well-being or common good, or the best outcome that we are expecting. Sometimes it's more related with the story of the people, how they perceive themselves about the risk, their lives. No, so it's a little it's more qualitative. Sorry, the method that we need to include here, but at the end we can translate it in a quantitative measures. I think equity indicators is something necessary to include in all these levels of information. Accessibility and health literacy, it's something necessary too. And speaking about the system efficacy, probably is how they could improve, better source allocation, faster responses in terms of public health needs. And finally, trust, transparency is something really important to include. So it's not only to see the side of the health provider system. It's how we are integrating all of these loops of information, creating these specific metrics that we desire to have, like something that we aspire to have one day.
Absolutely. Yeah, thank you. Okay, maybe we'll open up for some audience questions now. If anyone has anything they'd like to ask of our panelists. Otherwise, I've got plenty of questions. Anyone?
Yes, thank you very much. So I'm Tim Weber at the Eck Institute for Global Health. I'm going to ask a question as a retired healthcare system administrator, particularly in rural health. Certainly, there's a lot of AI in healthcare systems already. The big players are moving forward, certain others. The problem in the US healthcare system, particularly, is a growing problem with lack of providers, particularly in rural settings. So public health at a grand scale is useful, but at the end of the day, there needs to be providers in Southwest Indiana where there are none. Do you see any examples out there, or what you envision how AI can actually be useful to see the patient, who, by the way, there's less resources on the health system, there's less resources to pay for the healthcare, so it also has to be cost efficient. So I'm curious.
Go ahead.
I would say we're very close. I mean, I don't know how familiar you are with I'm losing the name of it right now, but all of our students are talking about these AI interviews that they're doing these days. So they just sit in one of the rooms over in Corbett Hall or whatever and sit in front of a computer, answer canned questions, and then the AI analyzes their interview and decides whether they're going to bring them in for a physical interview. The technology that they're using for that, I have to believe that we'll be using this for telemedicine in a short time. I mean, it doesn't get you around all the problems of, well, I actually need to, take your blood pressure and look in your ears and all of that kind of stuff. But it does get you through some of the early stage stuff. AI is impossible to predict these days. Just when I say, oh, it's going to be 3 years out, 3 months later, I found out that that's done already. So, it'd be silly to say when, but I think it has to happen within a very short amount of time.
Can I just Nice to meet you in person. We talked on the phone, right? So I'm not sure you're aware. There's last year, whose phone is ringing? Last year there was a call.
Something in the bag over here.
Oh, it's not mine. Yeah. There's something called Big Beautiful Bill. Have you heard about it? It sounds very Donald Trump, and it is Donald Trump. So they have this kind of 50, gosh, I couldn't remember. It's $50 billion federal grant that every state is eligible to apply to. So to improve rural house, it's just called the Rural House Transformation Program. It's the $50 billion that each state actually entitled to get $1 billion. And Indiana State actually put together a proposal last October, November, that time frame. And now surprisingly, it got funded because there's $50 billion, 50 states, right? So, but we didn't get $1 billion, we got $200 million. And one of they have like 12 initiatives in the proposal. One of the initiative is AI and digital health. So I contribute a little bit, but I didn't get any money. I have to reply for any funding. But so I think I couldn't recall the detail, but there are some like really crazy ideas such as digital twins, right? So you can build sort of like the digital you rather than sort of seeing the person like in person. You can test different treatment options, kind of to see what the results is. Rather than kind of really collecting the information from the data, from the person. So I mean, I think there's like a really fancy kind of technology you can leverage to either shorten the diagnosis time, or you don't have to see the individual patients, or you don't have to kind of use transportation to travel a long time and to go to the hospital or something. Yeah. So, but yeah, I would say there's a kind of really bright future, promising future out there for rural housing in AI.
Yeah, I can share another example. I'm not sure if you noticed, like the news 3 days ago, like use ChatGPT and AlphaFold, like attack boss create an mRNA vaccine for his dog cancer. So like this is really groundbreaking. So you can take a look and check the news. Basically, there's like a huge opportunity to bridge the gap or shorten the distance between non-experts by leveraging that kind of AI technology to better serve with that kind of disadvantaged population, rural areas. So here is like a very disruptive example, like how AI can help with many other problems that could not be solved. And yesterday, we just like launched like an end-to-end, like a cultivate research pipeline, basically from like a idea exploration, literature survey, towards like the methodology development, code writing, and also like doing experiments, even like a paper drafting. You can just like leverage that end-to-end pipeline, automate the entire process. The point I would like to bring out here is like my collaborator, even more aggressive. He believes in the next couple of years, most of the cancer could be resolved by leveraging like evolving technology, like, with the integration of domain knowledge.
I don't have too much experience working in the United States. We already started a project with La Casa de la Amistad trying to reduce delays to receive diagnosis and treatment in breast cancer. So the way that we are resolving, for example, the lack assistance, or the lack access to medical care is using the community health workers and I'm using the infrastructure that have the La Casa de la Amistad, and I'm inserting an educational intervention, trying to inform about signs and symptoms of alert, okay? And I'm creating a reference system, okay, to guide the women, okay, to seek medical care on time. I would like to share my experience working with indigenous groups in Mexico for 5 years, tracking 15,000 families, okay? And the solution that I found was, okay, using trains with different teams, pediatrics, pediatrics oncologist and gynecologist. And we also have dentist, okay, in this train, pharmacy, and a big system, okay, that is connecting virtually with different centers in all the territory. So every time that we need, the voice of the specialist to diagnose children, okay, they are available. This idea is similar to this idea of telemedicine. But at the end, we figure out how to move that children, okay, at least to the next village, okay, in order to find how to receive medical care in time. So I know it's a different context, but I think always are solutions, and I think it's not necessary to invest tons of dollars, Sometimes the answers are on field, and people can help us to understand how to provide that help that they are needing.
And I wonder, even indirectly, what I thought, Fanny, you were getting at it first was indirectly, I think one of the biggest benefits of AI that has been proven so far is equitable access to education. So I think if we, maybe improve upon personalized education and make it so that those in rural areas can become doctors easier, right? That might also be an indirect benefit. Might have time for one or two more questions. Does anyone else have anything they'd like to ask?
Hi there. With the prevalence of AI making decisions in public health, how confident are you that these AI engines actually have access to enough data? My understanding, I'm not a doctor, I didn't work in healthcare, is that hospitals protect their data, doctors' offices protect their data, providers in general, data is currency. So if you don't have the right data, are you confident enough that the AI engines are spitting out the right recommendations? And if that is a problem, how do we change that?
One particular practical solution is there are many kinds of medical GPT that is pre-trained based on the publicly accessible data. For example, those kind of survey data from enhance and many other publicly released data that can be used for the pre-train of that kind of conventional medical chatbots or build that kind of foundation models for medical domain. And then with this pre-trained model, for particular agency system, they can just use their private data to fine-tune that pre-trained model to serve and to better solve the problems that privacy matters.
They have to have access.
Maybe I add a few technical points to that. So that's a legitimate question. I could be 100% agree. If without the high quality or enough data, there's no way you can train a trustworthy AI system. From a technical perspective, there are different approaches. There's something called conformal prediction, which, for example, let's say if I predict something from a class, the class there are 10 categories. Rather than predict one class, you predict a set with 95% confidence. So that helps to deal with the uncertainty of making a single point prediction. So it's kind of give you, okay, I'm not confident about something. I'm confident without making the set of prediction rather than that. So that's one sort of technical approach. The other approach is called probably Fanny and all the machine learning people familiar with, called transfer learning, right? So you have a lot of data in one domain, but this somehow can be leveraged to train a model in a different domain. That's, as Fanny mentioned, so called like fine tuning, right? So you don't carry the whole system into a new domain, but but you don't have to start from scratch. There's some information you can leverage, but you can sort of make it better and suitable for the new domain based on what you have before, kind of incorporate the new knowledge. There's another sort of technical approach. People, this, as I mentioned, is a very legitimate question and a very research active area, for sure. Good question. Thank you.
There is this, Fanny referenced multiple. I'm aware of one GPT's open evidence, it's called. The challenge with open evidence is that it's not going to give you population. It's going to give you vast population, but it's not going to give you South Bend, Indiana population level data. You know, you're going to have to train your own GPT to do that. And, you know, some healthcare systems are doing this. They're building their own private LLMs, but it's not widespread yet. And until it is, you know, you're going to have these large, you know, LLMs that are trained on data from literally the entire United States. But is that going to help me in the west side of South Bend? Probably not until I have my data that couples with that data.
You had also mentioned earlier, like the role of federated learning.
Yeah.
Do you think that could play a role
That's
here?
one way. That's I think that's sort of kind of covered the question you mentioned. Maybe the data are siloed, right?
Yeah.
So it's cannot really shared across different entities. But federated learning is one way kind of aggregate data together, especially, for example, in areas such as rare disease. So you only have a few patients within just in one country versus the other one, but you don't want to share the information. Maybe you train a model within each of the countries and share sort of the aggregate level. There's something called gradients, whatever, and you kind of send the aggregate information into a central server, and it's become more powerful. And you send the model back to the local server, and they gonna. But you never share individual level information during the whole process. It's all aggregate information. In some sense, it's privacy sort of protected, but people already also done research showing that it's not the case. Actually, federated learning, you can actually leak more information than you expected, and that's where DP, differential privacy, comes in. Yeah, there's like differential privacy, federated learning, that kind of thing. Yeah, but yeah, federated learning is definitely a way to deal with that for sure.
Okay, well, I mean, I think we're just about at time here. So thank you again to our panelists for all your insights. One more round of applause for that. Thank you to Lucy and all of the help from you all. So thank you for being here today. And yeah, hopefully I'll see you all at the third panel, which is April 15th in the same ring. That panel will be on hopeful machines.